Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. We'll review effective bag mask ventilation using both single and two-person techniques. We'll review the steps of responding to a respiratory arrest and the recommended use of waveform capnography to monitor and confirm the placement of advanced airways. Before we get into the specific airway skills, let's review the recommended ventilation rate for cardiac arrest patients. For patients in cardiac arrest, provide 2 ventilations with the bag mask device after every 30 chest compressions. After inserting an advanced airway, healthcare providers should continue ventilations by providing asynchronous ventilations once every 6 seconds. If a patient is in respiratory arrest and has a pulse but is not breathing, ventilate once every 5 to 6 seconds. After 2 minutes, reassess the pulse. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart, so it lowers cardiac output and the patient's chance of survival. Tidal volume should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Let's begin with basic airway skills. The first 2 steps in any airway management response involve opening and clearing the airway. First, open the airway by using a head tilt chin lift maneuver. Place one hand on the forehead and one on the chin, and push with your palm on the forehead to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is typically performed on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. If the jaw thrust does not open the airway, use the head tilt chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Providers should suction the airway immediately if there are copious secretions, blood, vomit, or a foreign body. Use large bore, non-kinking suction tubing and a large suction catheter with a rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are 2 types of airway adjuncts: the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. To use the adjunct, insert the OPA so that it curves upward, with the tip pointing to the hard palate. As the OPA passes through the oral cavity and approaches the posterior wall of the pharynx, rotate it 180 degrees into the proper position. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. OPAs that are too large may obstruct the larynx or cause trauma to the laryngeal structures. OPAs that are too small or inserted improperly may push the base of the tongue posteriorly and obstruct the airway. Healthcare providers should insert the OPA carefully to avoid soft tissue trauma to the lips and tongue. Remember to use OPAs only in unresponsive patients with no cough or gag reflex. If the patient has a cough or gag reflex, the OPA may stimulate vomiting and laryngospasm. Only healthcare providers trained in the proper use of an OPA should attempt its insertion. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. Before inserting an NPA, lubricate the airway with a water-soluble lubricant or anesthetic jelly. Insert the NPA through the nostril in a posterior direction perpendicular to the plane of the face. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. If you encounter resistance during insertion, gently withdraw the NPA a centimeter or so, slightly rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head or facial trauma because of the risk of misplacement into the cranial cavity. With a known basal skull fracture, an oral airway is preferred. Take care to insert the NPA gently to avoid complications such as tissue injury or bleeding. An NPA may also cause laryngospasm and vomiting. An improperly sized NPA may enter the esophagus and cause gastric inflation with active ventilation. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. First, let's look at the device itself. A bag mask device is composed of a self-inflating or flow-inflating bag that is attached to a clear, cone-shaped face mask that covers the patient's nose and mouth. The edge of the mask has an inflatable cushion, enabling a tight seal around the nose and mouth when the provider applies pressure to the mask and lifts the jaw. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the three remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver one breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 5 to 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the two-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. When using a bag mask device, whether there are 2 providers delivering breaths or just one, be careful not to press too hard on the mask, which could push the patient's jaw down and obstruct the airway. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. With careful attention, trained healthcare providers can use an advanced airway to safely provide ventilation that is as effective as bag mask ventilation. Advanced airway devices offer many advantages. These include isolating the airway and reducing the risk of aspiration and gastric insufflation. After inserting an advanced airway during CPR, providers should deliver one breath every 6 seconds without interrupting chest compressions. Unfortunately, insertion of some advanced airway devices, like an endotracheal tube, may require interruptions in chest compressions that last longer than 10 seconds. These interruptions may reduce survival rates for VF arrest patients. It should also be noted that there is no evidence that advanced airway measures improve cardiac arrest survival rates in either in-hospital or out-of-hospital settings, so providers must carefully consider all these factors before performing the intervention. There are other advanced airway devices that healthcare providers can often insert without interrupting chest compressions. These include supraglottic devices such as the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. The American Heart Association recommends that you become familiar with a variety of devices, but master one primary method of advanced airway control. If you're unable to establish an advanced airway, continue ventilation with a bag mask device. The laryngeal mask airway is a supraglottic airway device that healthcare providers can insert without visualizing the glottis. In addition, it can be inserted during CPR while chest compressions continue uninterrupted. This makes training easier and insertion more reliable. The laryngeal mask airway is a tube with a distal inflatable cuff shaped like a mask that is placed in the patient's hypopharynx. Place the laryngeal mask airway in the open mouth with the opening of the mask facing the patient's tongue. Advance the device to the back of the tongue. In a smooth motion, use your index finger to press the laryngeal mask airway against the roof of the mouth and guide it downward. Continue advancing the device until you feel resistance, which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. Once inflated, the laryngeal mask airway will center itself in the mouth. If placed correctly, oxygen will flow through the lumen of the device and into the trachea. The laryngeal tube is a supraglottic device that can be inserted in an unconscious patient. Providers can insert the device during CPR while chest compressions continue. The device can also be inserted without visualizing the glottis. The laryngeal tube is a single lumen device with two cuffs inflated through a single inflation port. The distal tip of the tube is angled and beveled to easily slide into a collapsed upper esophagus. The design also reduces the likelihood of tracheal insertion. When the tube enters the esophagus, you should feel resistance. Inflate the cuffs with a single syringe. The esophageal tracheal tube is a supraglottic device that providers can insert during CPR without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of two lumens permanently joined. Each tube can be used to provide oxygenation and ventilation, depending on how it's inserted. The longer, blue tube, marked with a number 1, provides ventilation through 8 small side openings of the lumen in the pharyngeal section. The shorter, clear tube, marked with a number 2, provides ventilation directly through the lumen to the end of the tube. Once the tube is in place, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. The distal tip of the device will rest in either the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks airflow in and out of the esophagus, and ventilation occurs via lumen number 1 and through the small side openings into the trachea. If the tip of the tube comes to rest in the trachea, however, The rescuer can use lumen number 2 to deliver ventilation directly into the trachea. Caution: it's critical to confirm the proper placement of the esophageal tracheal tube, because if ventilation is delivered to the incorrect lumen, it will prevent adequate oxygenation and ventilation and result in severe hypoxia. Incorrect delivery of ventilation to the esophagus will also produce gastric insufflation that will complicate ventilation. The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or by providers who use it infrequently can produce serious complications, such as trauma to the oropharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. Despite the risks of intubation in inexperienced hands, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suction of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and, when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. To insert the endotracheal tube, place the patient's head in the sniffing or neutral position. Insert the laryngoscope blade into the patient's mouth. Lift the laryngoscope vertically up and away to expose the vocal cords and glottic opening. Insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of supraglottic airways. However, effective ventilation through these airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end-tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Connect the monitor between the advanced airway and the bag or ventilator. Waveform capnography provides a graphic demonstration of the carbon dioxide exhaled with every breath. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. In the patient with adequate circulation, The key uses for waveform capnography include the placement and monitoring of an advanced airway and the management of ventilation support. In cardiac arrest patients, waveform capnography reflects the effectiveness of chest compressions during CPR, and a sharp increase in end-tidal CO2 signals the return of spontaneous circulation. The higher the end-tidal CO2 pressure, the higher the cardiac output is during resuscitation. An end-tidal CO2 of less than 10 millimeters of mercury suggests that the cardiac output is insufficient to achieve ROSC. If the CO2 readings are low during resuscitation, the team should optimize CPR quality by minimizing interruption in compressions, delivering compressions at a depth of at least 2 inches and at a rate of at least 100 but no more than 120 compressions per minute, allowing complete chest recoil and avoiding excessive ventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. A sudden drop in waveform of 20 points or more could indicate a sudden, severe decrease in cardiac output that might be caused by a pulmonary embolus, acute blood loss, or a life-threatening arrhythmia. A decrease to 0 indicates no gas exchange or no carbon dioxide delivery, such as occurs with a displaced endotracheal tube, or the sudden stopping of blood flow, such as occurs with ventricular fibrillation. A rising baseline in the end-tidal CO2 waveform suggests that carbon dioxide is re-entering the side stream sampler during the inspiratory phase of ventilation. This reading might indicate that the patient is rebreathing carbon dioxide. This waveform has a prolonged phase 4, or inhalation, section. This suggests that there's air entering the trachea beyond the entryway that's being monitored. This happens if the cuff on the tube is deflated or if the tube is too small for the patient. In both arrest patients and post-cardiac arrest patients, ventilation and perfusion must be optimized to prevent lung injury, cerebral ischemia, and cardiogenic shock. The use of waveform capnography can dramatically enhance your ability to manage cardiopulmonary patients. Another type of CO2 detector, the colorimetric end-tidal CO2 detector, simply changes color when it detects CO2. One additional confirmation device is the esophageal detector device, or EDD. The EDD is a bulb that providers compress and attach to the endotracheal tube. If the tube is in the esophagus, the bulb will not re-expand and fill with expired CO2. An alternative model is a large aspiration syringe attached to the tube. If the endotracheal tube is properly placed, providers will have no difficulty retracting the plunger. Esophageal placement will prevent plunger movement. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.